Okay, so heart failure in the UK. Did you know almost 1 million people are diagnosed with it? It's a pretty staggering number, really.
Yeah.
And unfortunately, it looks like that number is only going up, with an aging population and, well, obesity rates still climbing. It's kind of a sobering thought because it's something that could affect us directly or, someone we love.
Absolutely. And it really highlights why we're diving into this today. This NICE guideline, it's incredibly comprehensive, for diagnosing and managing chronic heart failure in adults. Really important stuff because the goal here is, well, to help people live longer with this condition and crucially have a good quality of life.
Right, exactly. And just to be clear, because NICE has guidance on acute heart failure too, we're zeroing in on chronic heart failure today. Think of it as a fast track to the most important info from this guideline, our mission. We want to break down these recommendations so you can understand diagnosis and management without getting lost in the details.
So where do we even begin with a guideline this massive? I'd say the foundation is how they organize care. They stress this team-based approach right off the bat.
Okay, team-based. So who makes up this team? The guideline mentions a specialist heart failure multidisciplinary team. Kind of a mouthful, but what does that actually mean?
Yeah, MDT for short. And NICE recommends 3 core roles in this MDT. First, you have the lead physician, usually a consultant cardiologist specializing in heart failure. They take the lead on the diagnosis. Then there's the specialist heart failure nurse, who really becomes a key contact for the patient, a kind of support system. And lastly, there's a healthcare professional specializing in prescribing those specific heart failure meds. They ensure the medications are managed safely and effectively.
It makes sense that it takes a diverse team to really handle all the complexities of heart failure. It's not just a one doctor kind of thing.
Definitely not. And the MDT, their role is quite broad. They handle the initial diagnosis, of course, but also those difficult conversations when someone's newly diagnosed. They manage people at different stages, too, from the newly diagnosed to those whose heart failure has worsened recently, what we call decompensated heart failure, and even those with advanced heart failure. That's NYHA, Class 3 or EV, which means daily life is pretty significantly limited by symptoms.
So the more challenging cases, they go to this specialist MDT.
Yeah, pretty much. They also optimize treatment plans, start any new specialist meds, and manage patients after procedures, like if they've had a defibrillator or a cardiac resynchronization device implanted. And this is crucial, they deal with those cases where heart failure just isn't responding well to the usual treatments.
Okay, so that's the specialist side.
Yeah.
But where does the primary care team fit in? Like the GP, are they still involved?
Oh, absolutely. The guideline's very clear. The specialist MDT works with the primary care team. They have ongoing responsibilities, even when the patient's under specialist care. Communication's a big one, making sure everyone's on the same page. They also lead the reviews of the patient's overall heart failure care, which often ties into their long-term condition reviews.
So keeping the bigger picture in mind.
Exactly. They also set up regular reviews, at least every 6 months, and keep those clinical records updated. A big thing is making sure any changes to treatment or the records are understood by the patient, and then those changes are communicated to the MDT. And naturally, they're the ones who arrange access to specialists if the patient needs it.
So it's a well-coordinated dance between the two teams, which is, I imagine, essential for a chronic condition like heart failure. Now, the guideline also mentions a written care plan. Why is that important?
Oh, it's a vital tool. The specialist MDT creates a summary for each patient with heart failure, like a cheat sheet. This covers the diagnosis, the likely cause of their heart failure, all their medications, and details about those medications, monitoring, reviews, any support they need to take them properly.
This is like a snapshot of their whole situation.
Yes. And it goes beyond just the medical stuff. It outlines their functional abilities, any social care needs, their social situation, even things about their carers. This then feeds into a more detailed, complete care plan.
What kind of things would be in this full plan?
Okay, so the care plan outlines exactly how they're going to manage the person's heart failure moving forward, scheduling those follow-ups, any rehab programs, how to access social care, that sort of thing. Then it lists specific symptoms to watch out for. Like, hey, if you see this, things might be going south.
Okay, like a warning system.
Exactly. Then it explains how to contact the specialist MDT if needed, gives them a name and number for a coordinator, usually that specialist heart failure nurse we talked about, and tells them about alternative local providers for urgent stuff. Then it lists some reliable information sources the patient can use, to learn more about their condition. And copies go to the patient, their family or carer, and everyone on the healthcare team. I've seen firsthand how much this can help reduce anxiety for patients. It's like they have a roadmap.
Right. It makes them feel more in control. Having all that info in one place for everyone to see, that must make a huge difference in managing things well.
Yeah.
Okay, so team structure, care plan. Got it. Now, how does heart failure actually get diagnosed? What's that process like?
Well, the guideline lays it out step by step. Starts with the basics, taking a detailed medical history, a thorough clinical exam, then specific tests to confirm or rule out heart failure. And right away, they emphasize measuring this thing called NT-proBNP. It's a biomarker.
NT-proBNP.
Hmm.
Bit of a mouthful. What is it and why is it so important?
It's a hormone released by the heart muscle when it's under stress, stretched, or under pressure, which happens in heart failure. Think of it like a distress signal. High levels in the blood can be a strong indicator of heart failure. And NICE gives specific NT-proBNP levels that should trigger a referral for specialist assessment and an echocardiogram, which is an ultrasound of the heart. So this biomarker helps determine the level of risk, but it's not perfect, and we have to interpret the results carefully.
So what are those key levels we should be aware of?
Okay, so if someone's NT-proBNP is above 2,000 nanograms per liter or 256 picomoles per liter, that's high, and it suggests a worse outlook. Urgent referral within 2 weeks for assessment and that echo. For levels between 400 and 2,000 engliters or 47 to 236 pmol, referral within 6 weeks is recommended.
And what if it's lower than that? Does that mean they don't have heart failure?
Well, if the NT-proBNP is under 400 engliters, or 47 pmol, and they haven't started treatment yet, it's less likely to be heart failure. But, and this is key, it doesn't rule it out completely. They should still look for other possible causes for the symptoms, and if there's still a concern, talk to a heart failure specialist.
Okay, so it's not a definitive no, even if it's low. Are there other things that can affect those NT-proBNP
Yeah.
levels? Things that could throw off the result?
Absolutely. The guideline mentions quite a few factors that can either lower the levels, giving a false negative, or raise them, leading to a false positive. For instance, obesity, having African or African Caribbean family background, or being on certain medications like diuretics, ACE inhibitors, beta blockers, ARBs, or MRAs can all lower those levels. On the other hand, higher levels can happen not just in heart failure, but also in people over 70, those with a thickened heart muscle, reduced blood flow to the heart, a fast heart rate, pressure on the right side of the heart, low oxygen levels like from a pulmonary embolism, kidney problems, sepsis, COPD, diabetes, even liver cirrhosis. So basically, NT-proBNP is helpful, but you have to look at the whole picture, all the clinical findings, not just the number itself.
So it's a piece of the puzzle, not the whole puzzle.
Right. And that's where the echocardiogram comes in. It's essential for checking for valve disease, seeing how well those ventricles are working, both contracting to pump blood out, which is systolic function, and relaxing to fill with blood, that's diastolic function, and seeing if there are any abnormal connections within the heart called shunts.
Are there any guidelines on how that echocardiogram should be done to make sure it's accurate?
Oh yeah, the guideline stresses few things. High-resolution equipment is a must for clear images. And the operator, they need to be experienced, well-trained, meet those professional standards. It also mentions that the demand for these tests shouldn't compromise the quality. And sometimes a standard transthoracic echo isn't enough. They might need to consider other imaging like radionuclide angiography, cardiac MRI, or transesophageal echo if the images aren't clear.
So beyond the blood test and the echo, are there any other tests they typically do for suspected heart failure?
Yeah, there's a bunch. An ECG to check the heart's electrical activity, a chest x-ray to look at the heart and lung size and shape, and then blood tests like kidney function, thyroid function, liver function, cholesterol levels, HbA1c for diabetes, a full blood count. They also recommend a urinalysis and lung function tests like peak flow or spirometry. It's really about getting the full picture, making sure they're not missing anything.
It sounds comprehensive, that's for sure. So, once they've got all this info and they've diagnosed chronic heart failure, what's next?
Well, once the diagnosis is made, the guideline is all about assessing the specifics. They determine the severity of the heart failure, figure out the cause if they can, identify any triggers that might have started it or made it worse, figure out exactly how the heart's not working properly, and see if there are any underlying causes that they can actually fix with treatment.
Okay, so that's diagnosis. Now, treatment. The guideline has a whole section on treating heart failure with reduced ejection fraction. What are the main treatments they recommend?
So when the ejection fraction is reduced, it means the left ventricle, the heart's main pumping chamber, isn't pumping blood out efficiently. For this, Guideline recommends ACE inhibitors and beta blockers specifically approved for heart failure. They do say the doctor should decide which to start first based on the individual patient.
Right, so those are both common medications for heart conditions. But it sounds like the guideline gives very specific instructions on how to use them for heart failure.
Yeah, for ACE inhibitors, they're cautious. If they suspect valve disease, they won't start them until a specialist sees the patient. And they start low, increase the dose gradually, maybe every 2 weeks, until they hit the target dose from the clinical trials or the highest the patient can handle. Monitoring is key. They check sodium, potassium, kidney function, all before starting the ACE inhibitor, then 1 to 2 weeks after, and again every time the dose goes up. Blood pressure is monitored before and after each increase too. Once they reach that target dose and the patient is stable, monitoring can be monthly for 3 months, then at least every 6 months if things stay
A
stable.
lot of monitoring.
For sure. And beta blockers, they're similar. Start low, go slow, increase the dose bit by bit, checking heart rate and how they're doing after each increase. Blood pressure before and after each dose change too. An interesting point, the guideline says not to hold back on beta blockers just because someone's older, or if they have other conditions like vascular disease, erectile dysfunction, diabetes, lung problems, or COPD. And if someone's already on a beta blocker for something else, and then they develop heart failure, they might switch them to one specifically for heart failure.
Okay, what if someone can't tolerate those ACE inhibitors? Are there alternatives?
Yes, if there are bad side effects, the guideline suggests an ARB, an angiotensin II receptor blocker, specifically for heart failure. Starting and monitoring those is very similar to ACE inhibitors, low dose at first, gradually increasing, keeping an eye on sodium, potassium, kidney function, and blood pressure. And if neither ACE inhibitors nor ARBs work, they suggest talking to a specialist and maybe trying a combo of hydralazine and nitrate.
I see. The guideline also mentions MRAs, mineralocorticoid receptor antagonists. When do those come into play?
MRAs, they're added on if someone still has symptoms despite being on an optimized dose of ACE inhibitor or ARB, and a beta blocker. Monitoring those is key too, checking sodium, potassium, kidney function before starting, after each dose increase, and then regularly once they're stable. Blood pressure monitoring is important with those as well.
So it's like a step-by-step approach, starting with ACE inhibitors and beta blockers, then adding MRAs if needed. Are there other medications specifically mentioned for reduced ejection fraction?
Yeah, there are a few more specialized ones for certain cases. Ivabradine for people with stable chronic heart failure, a specific heart rhythm called sinus rhythm, a heart rate of 75 beats per minute or higher, and low ejection fraction, even if they're already on other treatments. Then there's sacubitril valproatin for symptomatic chronic heart failure with reduced ejection fraction if they're already on a stable dose of ACE inhibitor or ARB. The guideline emphasizes that specialists should initiate these more specialized treatments. They also mention hydralazine and nitrate together, particularly for people of African or Caribbean descent with moderate to severe heart failure. And lastly, digoxin might be an option for worsening or severe heart failure despite other treatments, but they recommend getting specialist advice first. And they say you don't usually need to monitor digoxin blood levels.
That's a lot of detail on reduced ejection fraction. What about other types of heart failure, like preserved ejection fraction, where the heart squeezes normally but the ventricles don't fill right?
Right.
Any specific treatments for that?
While the guideline is very specific about reduced ejection fraction, it gives general principles for managing all types of chronic heart failure. A big one is using diuretics for fluid overload, whatever the ejection fraction. They help get rid of that excess fluid and the dose is adjusted as needed, especially when other heart failure treatments are started. They do say that people with preserved ejection fraction often need a lower dose of diuretic, and if it doesn't work well, they need more specialized advice.
Okay, are there any medications they advise against in heart failure?
Yes, they specifically caution against certain calcium channel blockers like verapamil, diltiazem, and short-acting dihydropyridines in people with reduced ejection fraction. They can make things worse.
What about other common heart meds, like amiodarone, for rhythm problems?
For amiodarone, they say to consult a specialist before prescribing it for heart failure. And if someone's already on it, they need to review it every 6 months, check their liver and thyroid function, and look for side effects.
Makes sense. What about anticoagulants, blood thinners? When are those recommended?
If someone has heart failure and atrial fibrillation, They point to the separate NICE guideline on atrial fibrillation for advice on anticoagulation. They also highlight that you have to consider the impact of any kidney or liver problems when choosing and managing these therapies. For people in normal sinus rhythm, meaning their heart's beating regularly, they should consider anticoagulants if they've had blood clots before, if they have a left ventricular aneurysm, which is a weak spot in the heart's main pumping chamber, or if a clot's been found in the heart.
Okay, what about preventative measures, like vaccines?
Oh, yeah. They strongly recommend everyone with heart failure gets a flu shot every year and a one-time pneumococcal vaccine.
To prevent those infections, good idea. What about lifestyle advice? Anything specific about diet, fluid intake, exercise?
Interestingly, they don't routinely tell everyone to restrict salt or fluids. They say to ask about their habits and only advise restriction if it's clinically necessary, like limiting fluids if their sodium gets too low from too much fluid or cutting salt if they eat loads of it. But they do warn against salt substitutes with potassium because that can be dangerous for some. For smoking and alcohol, they direct you to the other NICE guidelines. They say air travel's usually okay, depending on the person's condition, and for driving, they say doctors need to keep up with the DVLA guidelines. So it's more about tailoring the advice to the individual, not just blanket rules.
So it's personalized, which is good. Now, once someone's diagnosed and on treatment, how important is monitoring?
Super important. They emphasize regular monitoring for everyone. This includes assessing their functional capacity, meaning how well they can do everyday stuff, their fluid status, checking for swelling, their heart rhythm, at least checking their pulse, their thinking and memory, and their nutritional state. And they review their medications, looking for side effects, and check kidney function with blood tests. This is the minimum, though. If they have other health issues or are on multiple meds, they'll need more frequent or detailed monitoring. How often they're seen depends on how stable their heart failure is. If things have changed, they might need checks every few days or weeks at first. But if they're stable, checks at least every 6 months should do it.
Okay, and does that NT-proBNP test, the one we talked about for diagnosis, play a role in monitoring too?
They suggest it might be useful in a specialist setting for some patients, especially those under 75, with reduced ejection fraction and good kidney function. Basically, it can help guide medication adjustments.
Got it. We've talked about meds and monitoring. What about procedures, like more invasive stuff? Any guidance on that?
They do have some recommendations. For coronary revascularization like stents or bypass surgery, they say don't routinely offer it for reduced ejection fraction just to improve heart failure symptoms if the main problem is a weak heart muscle, not blocked arteries. But they do say to consider a specialist referral for a heart transplant if someone has really severe heart failure that isn't responding to treatment, or if they have something called refractory cardiogenic shock, which is a life-threatening condition.
What about implanted devices like ICDs, implantable cardioverter defibrillators? Those are to prevent sudden cardiac death.
Right. They're really big on having a conversation with the patient and their family before implanting one of those. Talk about the risks, the benefits, what could happen. Make sure they understand that the defibrillator part can be turned off if they want, without affecting the pacing function, and it can be turned back on later. Explain when they might offer to deactivate it and clear up any confusion about how it works. And give them written information, too. They also say to review the situation regularly, at least every 6 months, or if their goals change, or as part of end-of-life care planning. Basically, make sure the benefits of the ICD still outweigh the risks.
So it's a big decision, not taken lightly. What about things like cardiac rehab, those supportive therapies?
They strongly recommend personalized, exercise-based cardiac rehab for everyone who's eligible, unless they're unstable. It should always start with an assessment to make sure it's safe, and it should be offered in a way that's easy for them to access, whether that's at home, in the community, or at a hospital. It should include psychological support and education about their condition, too, and they need to know about the ongoing support they can get from their healthcare team.
Great. And lastly, the guideline talks about palliative care, which is a sensitive topic but important for advanced heart failure. What are the key points there?
They say not to routinely offer long-term home oxygen just for breathlessness in advanced heart failure, although it might be needed if they have other lung conditions, like severe COPD. They also say that risk tools shouldn't be the only thing that decides whether to refer someone for palliative care. If their symptoms are getting worse despite the best treatment, they recommend discussing their palliative care needs with the heart failure team and considering a formal needs assessment. They stress that patients and families should have access to palliative care specialists within the heart failure team. And for the last few days of life, They point to the NICE guideline on end-of-life care. It's a reminder that managing heart failure isn't just about medical stuff. It's about quality of life and supporting people through the tough times.
It's a whole-person approach, which is good to see. I also noticed the guideline recommends some areas for future research. What are the big questions they're still trying to answer?
Yeah, they highlight some important gaps in our knowledge. One is finding the best way to manage fluid overload in advanced heart failure out in the community. They're looking at different ways of giving diuretics like oral, subcutaneous, and intravenous, and comparing their effectiveness and cost. Another question is what's the best imaging technique for diagnosing heart failure? They're comparing cardiac MRI with the cheaper options like echocardiography, looking at accuracy and cost. Atrial fibrillation and chronic kidney disease are common alongside heart failure, so they want to find the most accurate NT-proBNP thresholds for those specific groups because the current ones might not be as reliable. And lastly, they want a more accurate risk tool to predict non-sudden death in heart failure to help with conversations about prognosis and palliative care referrals.
It's good to see they're still working on improving things.
Definitely. I think the key takeaway from this deep dive into the NICE guideline is that chronic heart failure is complex. It needs a well-coordinated, multidisciplinary, and really thoughtful approach to provide the best care.
Yeah, it's not simple.
If we were to sum it up, I think the most important things are the need for a collaborative team approach between specialists and primary care, the role of NT-proBNP in diagnosis, but remembering to look at the whole clinical picture, the step-by-step approach to medications, particularly for reduced ejection fraction, and the need for ongoing monitoring and management that's tailored to each person's needs, including lifestyle advice, rehab, and palliative care when it's necessary.
It really highlights just how complicated it is to manage chronic heart failure and how much teamwork goes into providing the best care.
For sure. And for those listening, maybe you're particularly interested in one aspect of this. Perhaps you want to understand NT-proBNP better, or see the specific criteria for meds like sacubitril/valsartan, or learn more about the benefits of cardiac rehab. The NICE guideline itself is a gold mine of information if you want to dig deeper.
This guideline gives us a solid framework for understanding and managing chronic heart failure. But the research they mention is a reminder that we're always learning and improving, pushing those boundaries of care and management. It makes you wonder what the future holds, what new discoveries will come along to improve outcomes and quality of life for everyone affected by heart failure.